Charlene got to the point where she said, I don't want any more treatment. You know, it's been too hard on me. You know, I'm not winning this time. I'm not beating this. You know, I'm ready for comfort care. So as that disease progresses, the palliative care focus really becomes more paramount. And that's that end of life piece as well. Now, during that trajectory, though, what we'll find is that there is kind of a transition downward, and they'll have a crisis, but they bounce back. You know, and like I said, every time my father goes to the hospital, he thinks, okay, I think this is it, Jeannine. And then he goes out and golfs 5 days a week again, and you just never know. That's the hard thing about it. Or like I said, families will tell me, but they beat the odds last time. Why can't they beat the odds this time? You know, and I'll say, well, your mom's situation is very different now, and here's what's going on. So I think it's important to really talk families through this trajectory. So let's take a look at the care that we can provide to older adults at the end of life. And one of the most important concepts to keep in mind is the importance of that interconnectedness between the body, the mind, and the spirit. And when we provide palliative care, we cannot just look at one component. And especially when we're looking at working with older adults, because older adults have this history behind them. They have wealth of information, they have wisdom, they have knowledge. They've been through the, you know, life with hard knocks. They've got experiences and relationships. And all of this comes together toward the end of their life. Let's look first, though, at the physical care for older adults and some of the considerations that you want to take a look at. First of all, what are the most common symptoms? Well, believe it or not, fatigue is really number one. Pain in about 50 to 75% of patients, but weakness, anorexia, the lack of energy can go with fatigue. Xerostomia is dry mouth, constipation, the appetite, early satiety, and dyspnea. Interestingly, I think fatigue is one of the most stressful side effects because they can't do what they used to do, and that's how they coped. Especially for older adults that are pretty high energy and you know, can't drive, they're too weak to, you know, to golf, to do their gardening and all of those different things. One of the things that we need to consider, though, with aging is some of the changes that occur in the body that really we have to consider the medications that we give them. How is it going to be different than giving these medications to a younger person? Because there's altered pharmacokinetics of how those drugs act in the system, and altered pharmacodynamics, which is how the patient responds and what types of side effects that they could get as a result. They have comorbidities as well, which means that they're not as resilient as they used to be. So one difficulty can really tip the scale. There's polypharmacy issues because of the amount of medications they take for their comorbidities and chronic illnesses. And the other consequences is that they have this therapeutic window that's narrow. Giving too much of the medication might cause delirium, but not enough might cause symptom distress. And then what about drug metabolites? So we really have to take a look at this pharmacologic piece very carefully. Some of the differences of pharmacokinetic effects in the elderly have to do with absorption in the GI tract, with distribution and how medications distribute themselves in the tissue, how they're metabolized or broken down and released from the body, and that's through both the liver and the kidneys. So let's just take a look at each of these. So for absorption, and we think about how many medications they take, there's an increased gastric pH and a reduced motility. So that's going to cause more problems, of course, with constipation. And we know that that's kind of a focus of older adults, is keeping their bowels regular. There's decreased motility, decreased digestive enzyme activity, and mucosal atrophy. So they have these little mucosal villi that absorbed well. These villi aren't quite as absorptive as they used to be. They don't suck the water, or they don't distribute things quite as well. So they have prolonged colon transit times and constipation, GI distress, appetite sometimes changes. And you really have to think about the oral agents you're giving them and what's going on with that individual patient. Let's talk about body composition and fat, because I get this a lot. And I'm going to talk about fentanyl patches specifically in relation to this. One of the problems as you get older, of course, you have more fat to lean body mass. So that could be one difference. But you also have a reduction in your total body water, higher risk for dehydration, low albumin, and anemia. So the consequences, well, let's say a fentanyl patch. You put a fentanyl patch on a patient, and the way it works is it has to saturate all of your subcutaneous fat first. Then 12 hours later, it starts working. It goes to the bloodstream because the onset is 12 hours after you put the patch on. If you have a lot of fat, like a heavier, older adult, there might be a delay in the onset. But then after it gets caught up, you might have an accumulation compared to a lean person. So I'm managing a woman right now. She has breast cancer. She's in her 70s, and she's pretty thin. And so we put a fentanyl patch on her, and 2 days after we put it on, she had pain for that last day. And the reason being is because she had very little subcutaneous tissue in her body, very little fat. She was very lean. She'd lost weight. And so the fentanyl patch took that, her subcutaneous tissue took the fentanyl, moved across the bloodstream, but then it drained the patch. So we had to go with it every 2-day rotation on her. So that you just have to adjust your medication. So you might have a delayed onset if you've got a lot of fat, delayed rate of elimination, and then increased plasma levels as well. So what about the low albumin? I have another patient in right now. Her albumin is 2.1. For those of you who don't know, normal is 3.4 to 5.0. So very low protein levels. Non-steroidal anti-inflammatory drugs are protein bound. A lot of pain meds are protein bound. Antidepressants are protein bound. If you don't have significant protein stores, you're going to have drugs hanging around systemically in the bloodstream, and that's what contributes to your side effects. More sedation, more confusion, more problematic. And that's why, again, we have to really watch the drug levels in patients. What about the kidneys and the liver? Well, in the liver, of course, there's going to be some changes, and so drugs are going to take longer to break down. In the kidneys, they don't clear things as well. In your patients on dialysis, sometimes those drugs accumulate in the system entirely. For example, morphine should never be used in a patient with renal compromise because it has metabolites that accumulate and cause oversedation and confusion. So it increases the drugs hanging around in the system, and your body just cannot get rid of them. Now the challenges with these, of course, and I'll talk about NSAIDs briefly, the challenges is that everybody is individual. So we need to keep these things in mind when we're managing patients, but at the same time, you want to have some standards as well. So with the non-steroidals, let's think about what some of the side effects are. Everybody takes these, right? Most people. Ibuprofen, Aleve, Naproxen, you think about it. How many of you have taken a non-steroidal in the last week? Okay, pretty common, okay? So what happens, though, is the side effects, they inhibit prostaglandins. Prostaglandins, they coat your GI tract, so if you take that away, you get gastric toxicity. They decrease your platelet aggregation, so prostaglandins, part of it make your platelets stick together, and it decreases that, so you have bleeding. They also allow your kidney vessels to expand and have good blood flow. So if you decrease that, it clamps down on those vessels and you get renal toxicity. So you can have kidney failure in a lot of patients who have inadequate pain management, and they're popping a lot of Advil during the day and exceeding the doses. They come in with GI bleed, they come in with renal failure, and all of these complications. Also, confusion, of course, that we don't think about, but it can certainly happen. You really need to use them with caution, monitor renal status, GI prophylaxis with a proton pump inhibitor, something like omeprazole or one of those. What about opioids? Definitely start slow, start low, go slow, and like I said, morphine has 2 toxic metabolites. One is called M3G and one is called M6G. M3G basically causes hallucinations, confusion, side effects. M6G is a potent analgesic that's more potent than morphine itself. So it accumulates and that morphine gets into the system and actually they get over-sedated. So you really have to watch the half-life. In patients with renal compromise, you want to try something else. Other thing for drug-drug interactions are some of the antivirals, of course, some of the things that patients are taking at home, like St. John's wort. Coumadin, of course, interacts with everything, and antidepressants. So we really need a good pharmacist to take a look at that. Overall, for guidelines for managing pain in the elderly, least invasive route, you might want to use a patch if they have a hard time forgetting to take their medicines. One of the other concerns I have is that we don't assess and manage pain as well in long-term care facilities. And so to really take a look at trying to stabilize their medication so they don't have to ask for it, things like a patch or something long-acting. If they have pain around the clock, we should be giving long-acting opioids. Start one thing at a time. Start low and go slow. Use a longer interval between doses. Longer time before titration. Monitor treatment and response and adverse events. Consider rotating if that treatment is ineffective. Weigh that risk-benefit ratio with NSAIDs because some patients may not be able to take them, and then consider all the other issues, and also the home and social environment and the plan of care, which I'll talk about later. Okay, let me tell you about another complication that we see, and that's delirium, and of course we see dementia. But this is George, and I worked with George for quite a while. He was a gentleman with with lung cancer actually, and he was cured of his lung cancer. He used to attend the support group that I facilitated for the last 20 years, and he'd come and say, I'm just here for the coffee, I have no cancer, but I just love to visit with people. Well, a couple years later, he ended up with prostate cancer, and he was not so fortunate this time around. He really, it had gone to the bone very quickly. It was diagnosed in the aggressive phase. So George and I used to meet on Friday mornings in the hospital cafeteria prior to group as his disease progressed, because he wanted to make sure that he had all the knowledge possible to manage his pain and his symptoms at the end of his life. And he wanted things well thought out and advanced. I mean, what a great guy. Well, as his time got closer to dying, his wife called me one Sunday and she said, Jeannine, I can't wake up George. He won't wake up this morning. Can you come by? So I go to the house, and by that time he was on hospice. So I go to the house, he's unresponsive, and I take his blood pressure and it's maybe 90/60. He's got very little urinary output in his Foley. You know, I comforted his wife and said, I'm sure, you know, it's looks like it's getting very close, you know, to him dying. Well, I didn't hear. I got busy Monday. On Tuesday, I got a phone call. He said, hey, Jeannine, this is George. He said, I heard you were over on Sunday. I wanted to let you know I haven't died yet, and I'm going out to lunch today. So, you may have similar stories, because when patients are getting close to the end of life, they do go through bouts of delirium, or we call it a death rally, where they'll all of a sudden wake up, they'll interact with family, they'll want to go for a ride in the wheelchair, they'll have pudding at the kitchen table with cookies at 2 a.m. in the morning, ice cream. These are all the stories people have told me. So this delirium, it's this disturbance in consciousness and alertness in that wake cycle, and it occurs commonly at the end of life. There is changes in not only cognition, but psychomotor activity, emotional lability. It really can fluctuate, and for some people you call it sundowners at night, where they have more delirium and then they're better during the day. And it's usually attributed to more than one etiology. Now what's interesting about delirium, and we're learning more about it because it's a common problem in the hospital, is that there are two types of delirium. One is a hypoactive delirium, and they look depressed. And I'm going to show you how to tell the difference between dementia and delirium. But they act depressed, they're not focused. There's been a change, though, in their behavior that is remarkable, something to note. The easier one to detect is something like George, where he comes in and out of consciousness, or somebody who's hyperactive. And if you've seen this, you know, they can't sit down. They're going, you know, all night long, exhausting the caregiver. You cannot reason with them. So here's some of the things to look out for the differences. For delirium, it's fluctuating. They're in and out of consciousness. They might be better a second and not better. Dementia is more steadily progressive, although they can also have good days where they're clear and worse days as well. One of the things that I really look for is that inattention, though. For a dementia person, they can look at you and say, yes, it's 1955, and Jimmy Carter is the President of the United States, and they will tell you, you know, that. But they can also get through accommodating where they'll tell you the truth, and you might not pick up dementia as well. Delirium, they won't look at you. They'll this inattention where they're not focused on you, and again, they can look depressed, or they can have the hyperactive delirium. And psychosis is common. And like I said, this is a common problem that we're starting to pay more attention to in hospitalized patients, especially, for example, in ICU, but we do know it happens at the end of life. So what do? Well, we try to find the underlying cause, look at the medications carefully, and say, okay, what has changed in the last, 48 hours. I saw a gentleman in the hospital last week, in fact, makes me think of this. 92-year-old gentleman came in. What gets blamed usually when patients are delirious? It must be the pain medicine, right? A lot of times for the older population, it's urosepsis, uremia. Urinary tract infections are a major cause of delirium, and also like a full bladder, nicotine withdrawal. So look to see if nothing has changed in their medication profile. Start thinking about other causes. It's not always the medications. So you try to eliminate that and modify that. You review the meds, what's new, when did the behavior change, and then also consider the paradoxical reactions to medications, because what happens is we start throwing a bunch of benzodiazepines on the patient, like Ativan or Haldol or, olanzapine, Zyprexa, and it makes the problem worse. It's almost better to get them off of the medications and then really try to start over and unpeel things and see what's going on. For home care, of course, is there a caregiver? What's their functional and cognitive status? Let me tell you, medication boxes. I mean, I'm young still. I hit 50 this year, though. I'm 50 years old. I can't remember if I took my morning vitamins or not. All of us forget. How many of you have been on a course of antibiotics and forgot to take them? I think everybody could say that. So we need little reminders, and there's a lot of tools out there. There's phone reminders, there's, medication boxes that talk to you. We can get all sorts of things in the home. So that might be kind of scary, huh? You think something else is talking to you in the home. Okay, so that's physical care. Let's talk a little bit about psychosocial care. So what about depression? Well, there's some thought that there's actually a lower incidence of depression in older adults, and In some of my research that I have looked at with patients with cancer, that's definitely the case. However, it still does occur, and it's a really important component of our care and something that we have to tune into. One of the things is that we lack assessment. We've got to start assessing depression better because it is one of the things that can occur. Patients also might be reluctant to share concerns, and there's this stigma, especially with older adults, that being on an antidepressant is a sign of weakness. So we have to start treating depression like a disease, just like diabetes, where there is a chemical imbalance. And for some patients, it may be situational to work through, but in other patients, it's long-term depression that's undiagnosed, that accumulates over time, and again, really affects quality of life. So you all know kind of the signs and symptoms, and what are some of the things we can do, and I'll give you a few examples. First of all, pharmacologic interventions, of course, are one of the things we do to manage depression, and they were better than cognitive behavioral therapy in one study, but we also know that just getting people out and about and interacting with other people can help. I just came from support group, met with a lady this morning at 10:30 till 11 before I ran to the Mansfield Center and was lost. Anyway, she is having a very difficult time with depression because she said, you know what, I have always been an active person. I have been a goer, I'm a volunteer, I do lots of activities, and now I'm weak, I'm tired. I've had 3 surgeries in the last year. She has some other grief issues, and she says, I am clearly depressed. She's on antidepressants, but that's still not enough. We have to look at the other holistic pieces that we can put in place. Patient education, counseling, you know, tapping into those resources, support groups. I talked to her about some groups that met in town. She had some grief issues, so I referred her to some grief therapy sessions. Massage, music therapy. There is one pharmacologic intervention if patients are having a lot of fatigue and depression. One of the things we use is methylphenidate, which is Ritalin. And that's if their depression or their fatigue is due to like opioids that makes them really sleepy. Ritalin picks them up and makes them more alert and more focused. It can actually increase their attention. So what we need to do is provide different types of palliative rehabilitation for patients. It sounds so simple. It sounds difficult, but it's simple just by talking about these things. Because I think one of the things that happens as patients draw closer to the end of their life is that they're so wrapped up in going to the doctor. They've got appointments galore. They're trying to manage symptoms, and they almost forget who they are. These are some of the things that patients have shared with me that have been helpful, and I'll tell a couple stories about some patients. This is Dwight. Maybe some of you know him. He was an amazing woodworker. Ended up with metastatic prostate cancer, and his wife used to say, all he's doing is he's sitting on the couch doing nothing. Ever since he got cancer, it's like he's sitting there just waiting to die. He was an old sergeant in the Army, or I don't know what rank he was. And it was funny because people would come to group. If they were 5 minutes late, he'd be like, you're 5 minutes late. You're 6 minutes late. He was Mr. Drill Sergeant. Well, so one day I said, because I didn't know he was a woodworker, and his wife shared this with me, and I said, well, tell me what you used to do. What did you used to do, Dwight, for fun? He said, well, I used to do a lot of woodworking. I don't know if anybody's been to the summer fair. He made all of those beautiful kaleidoscopes. One of the Lutheran churches on the West End, King of Glory, he carved all of those crosses in that church. He did beautiful work. He said, you know what? I haven't been to my shop since I was diagnosed with cancer a year ago. And so we said, why don't you make us something? A couple weeks later, and it was Christmas, he came with Rudolph the Red-Nosed Reindeer Christmas ornaments. Hand carved out of wood. They were absolutely beautiful. In fact, I should have brought mine today. Every year I hang that ornament on my tree. Who do I think of? Dwight. And what a great, gift he left for us. Then pretty soon we had salad tongs. Still using those salad tongs. Then the ladies in the group that were quilting, they had him making quilt hooks. He was so busy, he didn't have time to think about his disease anymore. He was busy doing what he loved that he forgot to do. What about support groups? Well, I'll tell you, I encourage patients to get into support groups, whether it's cancer, congestive heart failure, chronic pain, older adult groups. There's a lot of them available in our community. I facilitate a Friday group. Well, Anne is the patient with the purple sweater, and then Skip is the one in the middle. He's a character, and Charlene that you heard about is on the other side. Well, Anne was talking about how cold her head was because she had radiation therapy, and she said, oh my gosh, I am just freezing. And Char said, oh, I'm going to knit you a few head things. She says, it's going to keep you really warm. You can put it under your head. Well, Skip said, that is not the only place that you lose hair. He said, it's really, I never thought it would feel so weird down there, but it truly does. So, and who thought a cancer support group would be boring? Charlene, she knit him. Aren't they great? Yeah. She knit him a couple little special presents. They had drawstrings on them. Yeah. This is as close as he got. That's as close as he got to modeling them for us. We said, that's enough, Skip. Yeah. He's found a lot of applications. So I went and spoke on this cruise a few years ago, and I said, Skip, can I borrow your little things? I just want to at least show them off and show what a great job Charlene did. So I took the box, and when I looked at the box, I thought, oh my gosh, Charlene, she's so funny. And so I asked her one day, I said, Charlene, did you notice the box that you put those in? She's like, no. I just went down to the basement, I grabbed a box, and I put them in there. Well, it said Fancy Nut, or Trophy Nut Factory. So I think the joke was on Charlene, but it's been pretty funny. So a lot of different things that patients can get engaged in, and the fact that they forget about living when they're going through all of this stuff. So what about spiritual care considerations for older adults? First of all, what is spirituality? Well, it can be defined really broadly, that personal search for meaning and purpose in life, which may or may not be related to religion. The word spirituality is rarely used. In fact, patients won't understand what that means, but it really entails a lot of different things. And there was a meta-analysis by Edwards and colleagues in 2010, and what a meta-analysis is it takes every study done on spirituality and look for what are the commonalities where patients talk about their spiritual life. So it can entail stories about life, relationships with themselves and with others, with music, nature, relationship with God or a higher being, and what gives them hope, meaning, and purpose in life. And of course, religion is included in there as well. Some of the spiritual needs of older adults have been to finish business. In fact, I had a recent patient who passed away, and she kept saying, oh my gosh, I can't die yet, I've got to clean the basement. And there's other businesses, and her husband said, no, you don't. You do not need to clean the basement. In fact, her hospice nurses might be here today, I don't know. But to finish business, and it's that urgency to get things done. There's also a need for an involvement and control, and patients feeling like, oh my gosh, I've got so much to do in so little time. But they also want to have a positive outlook. Sometimes there's fear. Sometimes there's negative feelings. There's a lot of grief along the way, and losses can be in several ways. Losses can be something physically that they're not able to do anymore. They can't go out and play cards with their friends anymore. They can't go for a walk in the park. And they have increased healthcare utilization. In fact, oftentimes, those of us in healthcare become so intimately involved with these patients that we're like an extended family to them. For many patients, it's a search for meaning. And in the past, they want to talk about their experiences. You know, what was my life like? What were my successes? What were your failures? And even engaging in conversations with patients can really bring those types of things out. So for the present, they want to understand their current condition. Some patients are angry. Others are not. They'll say, oh, I've been so blessed. It's been a life that I've been blessed with, well led, I'm ready. For most patients, they will ask, what is going to happen to my family? You know, who's going to take care of my kids? What if my kids aren't doing well? Who's going to be there for them? Who's going to be there for my grandkids? And also, where will I spend eternity? And I find that even patients without a belief in God or a higher power still have a belief in an afterlife, which is interesting. But most patients will ponder all of these things. If we think about the developmental stage of older adults, and I still go back to Erik Erikson's and his stages, because really developmentally they're coping with the physical changes of aging and their losses along the continuum, and we all go through those, of things that we used to do and we can no longer do. In our mind we can do them. In fact, one day I thought I could still do a headstand. I can't do a headstand anymore, you know. I about killed myself. So it's that ongoing loss in that continuum, and a redirection of energy to new roles. They're caregivers, their life takes on different directions, and growing to acceptance is one of the accomplishments of this area of growth. Developing a point of view about death. What's that going to be like? Do I think about it a lot? Or is it something that I kind of put off and don't want to think about right now? The psychosocial crisis, of course, is in integrity versus despair, and it's really, is it okay to have been me? What did my life mean? Did I lead a life that was worthy? Did I do everything that I was supposed to do? What was that like? They're very introspective, thinking about these things. You know, the wisdom that comes is one of their qualities. And the overall definition is the detached yet active concern with life itself in the face of death. So while they're trying to actively engage in life, there's still thoughts that my days ahead are fewer than the days behind me. So how do we respond to these needs? Well, it's really the manner in which care is given, and the relationships with the health caregivers are really important to patients. And I was so impressed in this meta-analysis that they wanted professionals to step beyond those rigid professional boundaries where we don't go there. And we know that when we are privileged to be caring for patients at the end of life, when we're privileged to care for older adults as they're going through chronic illness, we're stepping into an intimate time for them where they're struggling, where they're vulnerable. And oftentimes, it's that bi-directional sharing where we grow the most and where we facilitate patient spiritual expression. So instead of being the quote-unquote therapist up here, we really need to get down to their level. Have a conversation. They want to know about you. They want to know about your kids. Where do you cross the line? And I always tell professionals this, when it's no longer the patient's needs and all of a sudden it's your needs. But sharing about each other really enables patients to respond to their own spiritual needs, to kind of step out of that rigidity and really start talking back and forth. Active listening is important, empathy, creating an environment to discuss spiritual issues, and sometimes that's hard. We're all busy. I think hospice and home care nurses do the best. You're also in people's environment. In the hospital settings, I think we definitely can do this more, but patients want to go there. And usually they will say it is the most neglected aspect of care. A few barriers, but we can definitely try to overcome them. Christine Pachalski is a medical oncologist. In fact, I spoke in the Middle East with her. We did a Middle Eastern Cancer Consortium. It was a 4-day meeting trying to help some of Middle Eastern physicians and nurses with pain management and end-of-life care. And she developed this tool. It's called a FICA. F stands for their faith. 4 simple questions we can ask them. What is your faith or belief? Do you consider yourself spiritual or religious? Even that. Is it important in your life? Because some patients will say too, you know what, I used to go to church. I used to be a very devout Catholic, for example, but wouldn't God be upset if I came back now? I haven't gone to the church in 30 years. Oftentimes, this is a time for patients to reconnect with their spiritual roots, and oftentimes they just need to be given permission. Are you part of a spiritual or religious community? And how would you like me or your healthcare provider to address these issues in your healthcare? So can we call a pastor? Can we call the chaplain? Can we call the medicine man? Can we call the rabbi? Can we call somebody in your life that can help you talk about these issues? In the FICA, you'll find it. If you Google it even, you'll find it online. Some of the things we can do as well in this phase is to really build hope and meaning by patients leaving their legacy with different stories, letters to their kids, cassettes, videos, journaling, planning their funeral, writing their obituary, and leaving a legacy. I have to tell you, Charlene wrote her own obituary, and she kept changing it. She thought she was going to die for 20 years. Well, she finally, in fact, it was so funny because it was October, but she told us all Merry Christmas and Happy New Year because she didn't know how close to the New Year it'd be. But she rewrote it again like 4 weeks before she died. And it was one of the funniest obituaries, of course. You've got to know Charlene. Funniest ones that I've ever heard. But what a great thing for her family to have that gift for her as she left. I tell this to young parents about leaving things behind, but I think it pertains to older adults just as much. I had a young gal who had metastatic ovarian cancer, and she ended up she was going to die, and the day she found out she was going to die, she called me to her room, and we were both sitting there crying, and I said, okay. I said, here's an idea. Now, your daughter, who was in 7th grade, was going to go with some caregivers. I said, leave her something for her 8th grade graduation, high school graduation, her wedding, her birthdays. She called me an hour later, and she's like, oh my gosh, you've got to come to my room. So I get there. She'd gone shopping in the gift shop. She had like 4 bags of goodies. She had presents for her birthdays. She had wedding gifts for her daughter, all those things. What an incredible gift that you can leave for your children. One of the nurses, I can't remember who it was, Jan, that her mother was a nurse, and she was 75 or 80 years old, and her mother published a book about her life and left her legacy to all of her children. Those are treasures that you cannot replace. So every patient has a story. Some patients physically need more support, some psychosocially, some spiritually. But the most important thing is that we uncover their stories, that we not only tune into the physical aspects of what's going on, but also those psychosocial and spiritual aspects. We have to learn the art of symptom management because we know pain and other symptoms can be effectively controlled in more than 90% of patients. And in the patients we can't control with simple measures, we never give up. We always try something else, and even those patients, if we have to sedate them, we will, but we will not allow patients to suffer. Because when comfort is not attainable, that palliative sedation and control of symptoms is always an option. But we do hold the keys to their comfort, so it's really important for that. This is our symptom care team at Billings Clinic. Wednesday, we meet. We look at patients. A lot of older adults come through our symptom management clinic. The non-cancer areas with Derek Weiss and some of our palliative care team, they have 2-day-a-week clinics as well, trying to look at how to manage symptoms, but what else is going on psychosocially with the patient, what's going on spiritually, what about their mobility and activity, what about their diet, you know, all these different modalities we address during these meetings, and then we meet with patients one-on-one. So we have to remember that if total suffering involves the body, mind, and the spirit, total end of care or end of life care must include the same. So with that, I will stop because I got the 5-minute sign. So thank you. Do we have time for any questions? Are we? I knew we were late anyway. You can always email me, jbrandt@billingsclinic.org, or get a hold of me for any concerns. Thank you, you guys. You are welcome. Well, and I knew. Yeah, it's 12:30. You did perfect.